E ele era motorista no Brasil. E então há uma vez We're on? Então há uma vez que estamos na Ericeira e eu e a minha irmã não tínhamos nada que fazer. E ele já não conduzia para aí há 10 ou 15 anos. E tinha lá o Volvo que o meu pai tinha lá deixado. E nós pensávamos assim, vamos à Ericeira comer uns bolos. E a Sara dizia, pá, mas como é que vamos? Tu tens 14 anos, eu tenho 10, ninguém sabe conduzir isto. E vamos pedir ao tio Artur. E tio Artur, como é que é? Vamos até à Ericeira? E ele assim, Ericeira? Mas isto é muito longe para ir a pé. E ele, não, está ali o carro. Então tio Artur era motorista. Bom, não estás bem a ver aqueles 3 km da praia de São Julião à Ericeira, como é que foram feitos? Era aquele... E eu ia estar lá atrás assim, eu estou com calma, se calhar era melhor voltar. E ele, não. Mas lá chegámos e a coisa correu bem. Bom, bom dia a todos, bom dia Darine, na Regi. A Regi está a ficar cada vez mais profissional, já temos 4 pessoas na Regi, tratadas de luzes, temos o Sebastião, depois a Darine, da Inglaterra temos o John, e agora da Holanda, recentemente, o Van Cliff, que é o responsável pelo som.
Para a semana veio o
Para a semana vem o Harvard. Bom, bem-vindos a mais um programa do What Would You Do, ok? É o programa número 18 e, epá, está-se a tornar já um clássico. Vamos até julho, depois temos outras surpresas, mas até lá ainda temos mais 4 ou 5 programas que vão ser bastante interessantes. Antes de mais, queria agradecer a todos vocês que têm carregado no sininho, que têm gostado de like, que têm feito comentários, porque realmente a página tem crescido a uma velocidade enorme e é graças a vocês que estão aí desse lado a dar like aos nossos conteúdos. E, portanto, comunidade, vamos manter-nos fortes e vamos conseguir chegar aos 1000 seguidores proximamente. Ok, 100 já temos. 500, ok? 500 seguidores. Se cada um disser a um amigo que este programa é fixe, chegamos facilmente aos 500 seguidores. Não se esqueçam também que este programa é suportado por toda... apoiado por toda a equipa do IAD Lisbon. Se não gostam da nossa página, pelo menos apareçam aqui na Avenida Liberdade. É maio, a avenida está muito bonita, não está? Está linda, portanto apareçam e toquem aqui no primeiro andar e um de nós pode-vos abrir a porta. Mas também pode não abrir a porta, também acontece muitas vezes. Mas isso não é problema. Ok? Exatamente, mas há sempre alguém que vai chegar, demora 5 minutos, meia hora, portanto também não há pressa, o mundo também não foi feito num dia, Saturno está a 4 milhões de anos de luz, aprendi isso no outro dia, portanto mesmo que Saturno desapareça, nós só sabemos da novidade 4 mil anos depois, portanto não há problema absolutamente nenhum. E portanto eu fiz-vos uma questão, ou nós fizemos uma questão neste What Would You Do Session, que era basicamente para a implantologia. Nós tínhamos um doente com 57 anos, na altura até me parecia um bocadinho mais velho, também não tinha dentes, é normal. Depois o João disse-me 57, e eu 57, fogo, realmente, as coisas sem dentes, as pessoas ficam mais velhas. E que precisava de fazer uma reabilitação com implantes nesta zona anterior. E eu pus esta imagem, este corte do CBCT, para vocês terem uma ideia de que havia algum osso disponível. E a pergunta, e portanto esta era a imagem que eu vos deixei aqui, portanto vocês veem aqui, esta é a provisória do senhor, aqui é a parte dos defeitos ósseos que eles têm. E portanto a pergunta foi muito específica, caros colegas. Era, mediante esta situação anatómica inicial, o que é que nós devíamos fazer? E foram colocadas 3 questões. Mas por um erro de sintaxe do programa de ChatGPT, ele copiou a terceira e então tínhamos, na verdade, 3 opções, mas 4 hipóteses. Era só para ver se vocês estavam atentos. A primeira seria, no fundo, abrimos aquilo tudo, fazemos uma regeneração óssea, fechamos aquilo tudo, esperamos 6 a 9 meses, independentemente do lá o tipo de regeneração que vocês fizerem, e colocamos os implantes e depois esperamos mais 3 meses para a reabilitação final. A segunda possibilidade é, ok, fazemos a regeneração e os implantes no mesmo dia, passado 3 meses, a prostodontia acaba o caso. Ou fazíamos não só a regeneração óssea, como fazíamos também os enxertos de tecido conjuntivo e depois, passado 6 meses, colocávamos os implantes, 3 meses depois colocávamos a prótese definitiva. E Darin, can you put the results, but with a new style? Can you press play? All right, thank you, Darin. And so here are the results. Okay, 88%. Don't laugh. I cannot do this if you're laughing. 8% of you said, okay, let's do rebuilding first and then place the implants later. 50% of you said, no, let's place the implants and the guided bone regeneration in one shot and then the prosthodontic finish. And more or less 40% of you voted, no, we need guided bone regeneration and soft tissue grafting, and then we wait 6 months and place the implants. These two were the same. Well, first of all, there is no right and wrong with this answer, okay? There is no right and wrong with this. Every one of you has different clinical skills, different backgrounds, so there is no right and wrong with the answer. The idea here is that what would we do in this situation? And then you can judge if our approach was good or bad, it has some flaws. The objective is this one, is that you can share the information. But obviously here, we have a religion, like João and Mariana calls, that is the religion of panda, okay? The famous quotes from Master Hu Wei and Master Shifu are always present, okay? If you didn't see the movie, go see the movie, the three of them, because there's a lot of interesting information. And with guided bone regeneration and tissue defects, Master Hu Wei has the perfect sentence, because it says, one often meets his destiny on the road that takes to avoid it. So it means that when you see a defect, you think, no, I have to throw everything to this defect, because if I don't do this, I will not reach a pleasant final. And then you throw everything, connective tissue graft, resorbable membranes, titanium mesh, LPRF, everything, you know, to try to avoid the defect. And the more you do, the more the probability of you have infections and things can go wrong. So this is the most appropriate sentence with this. So you have to choose the best clinical technique to the best clinical situation. And you saw the pictures and you said, okay, you have a lot of bone there. So in this case, well, I can go with the implants and the GBR at the same time, but the thing would be different if you have short amount of bone, you have lack of bone. And I decided to bring another case to elucidate that even with a short amount of bone, our clinical skill would say that in these cases, if you have enough bone to have primary stability of the implants, then you should know you can go with the implants and the guided bone regeneration. This is not the case that you see, this is another case, but see the difference on the bone that we have here. But still, we have lack of bone, but you have some bone on the apical portion. So this means this is lateral augmentation, you know, for sure it's a lateral augmentation, but you can place the implant and let, you know, the osseointegration pattern start from the day zero, because you can save a lot of surgeries to the patient. So this is a case that, see the fenestration that we have here, you can gain primary stability on the bone that is available, and then you can regenerate everything and still begin, you know, the healing cascade with the implant and the lateral bone augmentation in this part. Well, the lateral bone augmentation, you can do you want. There's not the topic here. The topic here is the conception of the treatment. Then, you know, the clinical skill of each one is different. But you see here that it's possible to gain primary stability and let the implants start to heal at the same time that you have guided bone regeneration. So after 4 months, the implants are integrated and you can start to shape your soft tissue with the provisional restorations. Well, in this case, Elena here is doing the orthodontics, so she needed the teeth in order to start to pushing, you know, all this occlusion together, right? Correct me if I'm wrong. Okay? Yes. We have yes from the ortho department. So we start to place the provisional restorations, and you see here that the implants are on the prosthodontic position. The hard tissue defect was corrected, and the patient after 4 months has a fixed solution on the interior teeth with everything solved. Okay, with one surgery, not multiple surgeries, one surgery. And then obviously this case is undergoing, but you know, the patient is very happy. Okay, the patient is very happy at this point. Is with provisional restorations. On the prosthodontic side, there's a lot of things to change, but the idea is the patient is very happy and very stable with this situation. The implants are stable, the soft tissues are corrected, the hard tissues are corrected with one single surgery, even in this type of defects. But moving to our case, okay, what did we do in this case? Obviously, we had more bone than the case that you see previously. So in this case, not a chance of this going to be a GBR case and then implants on other surgery. This is an implant case from the beginning with guided bone regeneration. No doubt about this. So João did a wonderful provisional. Applause to the provisional. Because this is very important with these type of cases where you have surgery and prosto and guided bone regeneration. It's very important that the prosthodontic knows, you know, that we need primary wound healing of these cases, so we need to be sure that is well away from the gingival tissues after surgery. So one of the most important things in surgery is how do you deal with the provisional restorations, okay? You cannot have, you know, a provisional restoration that is hurting the tissues while this is healing. So this is why it's very important you have a good prosthodontic field. So on the day of the surgery, you see here the hard tissue defect. you know, for the, it has a collapsed, it had collapsed lip support. And so in this case, what we did was a classic GBR procedure described in 1975 by Schenk and Boozer, where you use, you know, a xenograft and a resorbable membrane. Now, I know all of these guys who are watching, and some of them said, whoa, whoa, I would use a titanium mesh. No, here, definitely titanium mesh. Individualized titanium mesh for bone reconstruction. And I know others that would say, no, 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 this is autogenous bone. I'm going to take out some piece of the mandible and place it there. They're all correct, okay? They're all correct. You can do whatever you want. But just remember one thing. Here, do you need bone for osseointegration? João, do you need bone for osseointegration? You need bone, but there's native bone there, right? So the implant would be more or less 50%, 60% in native bone, right? So it will also integrate. So you have a collapse of the soft tissue. You need volume. You don't need bone. So if you ask me, is this a technique will give you a lot of bone? No, the vital bone probably is less than the titanium mesh or the autogenous bone plate. But is this less morbidity for the patient? For sure, one surgery, okay? So choose the correct technique for the correct case. These cases, for us, we do it like this. And, you know, you just have to be sure that you cover everything with the, you know, with the resorbable membranes. Be sure that you do your releasing incisions. Do everything that you are taught in the oral surgery and implant programs. Do your releasing incisions so you can have passive primary wound closure. And obviously, it's very important that, you know, the suture material that you choose and how do you suture these cases are very important for the outcome that you have on these particular cases. And here you see that we send to the prosto department these things like this. Everything closure, everything with the wound closure, the sutures are there. And so the prosthodontic picks up the cases and will trim the excesses here in order to allow for this to heal uneventfully, okay? So this is a classic technique of guided bone regeneration with simultaneous implant placement. The implants will be loaded after 3 months, okay? After 3 months. It's called a delayed implant loading. In here, you don't want to rush, okay? Bone will heal faster than the soft tissue in this case. Osseointegration will be faster than the maturation of the soft tissues. So here is the patient leaving the office. You see there's careful, you know, not to impinge the soft tissue here on the suture side. And then you see immediately after placement, okay? The implants were placed in the correct position, prosthodontic position. And then you see that after 3 months, you have a beautiful bone tissue volume on this side, okay? So when you do the stage 2 procedure and you go check if the implants are okay, nowadays you can do a CBCT with less radiation than a panoramic X-ray. Yes, 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 we bought a new CBCT machine that you can really do the 3D imaging without sacrificing radiation to the patient, which is awesome. And you can see now the bone volume that we gain and the implants on the correct prosthodontic position. So in this case, it is obviously that with one surgery, we could correct with xenograft and resorbable membranes the defect, the volume defect that the patient has over here. So it was clear for us that this was the procedure. You can see here a cut, and you can see that half of the implant is on native bone, and then the other half is on the regenerative part, okay? But you see here, you already know this. If I ask you what is the bone to implant contact that you're gonna see here, okay? It's around 40 would be great. 40 would be great. It's much less. It's much less. It's around 18 to 20%, okay, in the xenograft situation. So it's not the same as the autogenous bone, obviously, but you see here that you're gonna have some bone to implant contact over the area. But the idea is that you solve this situation with just one surgery for the patient, okay? Here you can see the before and after. Before, you said a big ledge, a big defect on the ideal prosthodontic position of these teeth, and on upper, we see that correction already. And the patient was very happy, okay? We did a jump leap, okay, from the surgery. This is the end result that you see how wonderful are my veneers. I'm such a good prosthodontist. You see here how I place this. No, it's joking. João is a prosthodontist. Come here, come here, come here, come here, come here. Another round of applause. And he received the patient after 3 months and did the final prosthodontic work that he can explain to you right now.
Okay, guys. So, very quickly, sorry, just to tell you, the concern here, besides, of course, all this area that has been surgically assessed, was the vertical dimension. So, making very short, we just, with the new provisional, we just recontoured the tissue at the end so that we could have a proper, I would say, gingival level, of course conditioning it with the provisional material. We were not very worried with the back teeth, as we were not only placing the screw retained crowns over the implants on the first quadrant, but as well on the second quadrant, then veneer lace to re-plan the vertical dimension and the correct posterior contacts. But I think the most important thing about this case is the way we managed it together in order to have the implants exactly in the place of the laterals and the volume right, so that we could have a very stabilized lip at the end, and I would say a very harmonious smile line and final stage. The patient is happy, we are happy as well, the implants are solid, and the tissue is really, really good, thanks to my great colleague and surgeon, Professor Chen.
Thank you, thank you, thank you. But it's important what you all said, because that is something that you don't hear a lot in the university. The patient was happy, okay? The patient was happy. The patient sometimes are not so happy when we do multiple surgeries. If we have to do it, we do it. It's not a thing that we try to avoid big surgeries, because one thing that we see a lot of in social media is that the most difficult case and the more blood you have and the more extreme is the case, it seems that it's better for the dentist. These guys do the amazing things. But just remember one thing, that on the other side of the blade, like a professor should always tell me, is a patient. Okay, and you have to choose the less morbidity technique with the highest predictability. And you have multiple weapons that you can choose. In these cases, the patients profit with only one surgery. Only one surgery. And João said the patient was very happy. And the patient being very happy is a halfway pass for him to bring multiple patients. The family. This patient brought the family, the friends. They bring everybody, because you choose the correct technique for them. Not everybody has this lucky. Sometimes you have to, do hard surgery, okay? And so whenever we go for that path, patients are not so happy, okay? Patients are not so happy. I was in a couple of meetings in May, and I met a lot of old friends. We are getting older. We are getting older. We are getting older. We are getting to 45 or 45 years old. And sometimes we look around and we are not young anymore. And it was funny that we were gathering with a bunch of dentists in Dubai, all of them with more or less my age. And you know what are their favorite? And these are big surgeons that you hear all over Lisbon and Portugal. You know what their favorite procedure is nowadays?
Extraction of the central.
Extracting of the central, or placing the lower first molar implant, okay, in a healed ridge, because they know that the surgery brings a lot of problems when you try to do multiple surgeries and big surgeries and try to invent something that is an over-treatment, okay, an over-treatment. So after these surgeons do thousands of all-on-4 procedures, all-on-6, all-on-X procedures, after they do a lot of regeneration, bone techniques, they come to a conclusion that is a simple procedure, highly effective, that brings less problems to the patient. So remember always this. And there was another example also this month of May, and I'm sorry to be so long in this podcast. I was in a meeting in the Gran Canaria, and my topic was the full mouth rehabilitation. And the first speaker talked about nerve transposition. Nerve transposition. You know, they open the jaw and they do the nerve transposition. Awesome technique, beautiful slides, you know, chapeau. Then the second one was on chapeau. You like the chapeau? I did my, okay, you like the chapeau. You know, I saw laughing the chapeau, okay? It's my French. I'm becoming better with my French. And then the second guy was horizontal autogenous bone from the mandible to correct the defects, you know? Also, wonderful cases. One of the best procedures I've ever seen in my life. And I came with the short implants, okay? Okay, I came with the short implants, you know, short implant, just bang, place the short implants, okay? And then the last one was sinus elevation and pterygoid implants, okay? So you have these 4 presentations, okay? Mine was a simple one, you know, it's a small, you know, short implant. It didn't have all this surgical, you know, wow from the presentation. And then we gather on a round table. And someone from the audience asked to the panel, if it was your mother or you, and you had 4 millimeters of bone, what would you do in your situation? The guy from the, you know, nerve transposition said, to our surprise, short implants. Okay, and I was, what? Short implants? Oh, okay, good. Yeah, my team, right? The guy from the horizontal bone regeneration said, short implants. And the guy from the pterygoid and the sinus elevation said very elegantly, if I have 4 millimeters of bone, in this time I would place short implants in my mouth. End of the story, okay? So it's very beautiful, all these surgical techniques, but you know, nowadays with these new tools, sometimes you have to relearn a little bit the procedures, okay? Try to be less morbidity. So here is the final part of the upper regeneration thing. Then we place the implants on the lower, and then João is going to place the final crowns on this patient on the lower. But the thing is that we solved the case in this situation, and to end up with a very elegant phrase from my friend, okay? It's not the size of the wand that matters, it's the magic that's in the stick, okay? Just remember this. Just remember this, that is very important. Because we all here in the clinic use very skillful the stick, okay? So don't miss the next show. Next week, we're gonna have pediatric dentistry, and thank you all for watching the show. Thank you.